Thanks. So I'm going to go through really around the country experience now, some of our experiences from South Africa, really around treating advanced HIV disease. And again, I'm going to start off with a case, if I can, and really to highlight the issues around that advanced HIV really increases the complexity of treating children. So this child is currently in the ward. It's a 2-year-old, was admitted with severe pneumonia and a dilated cardiomyopathy, had an HIV diagnosis on admission with a very low CD4 count percentage, was born via cesarean section, and the maternal HIV test at delivery was negative, which was exclusively breastfeeding from birth to about 7 months, and subsequently developed HIV during that time and wasn't diagnosed. So essentially, was not in the program and wasn't diagnosed through that time. So she was ventilated for around 10 days with PJP and had an adenovirus, required inotropic support, antibiotics, had seizures and a CT scan. We only could start the antibiotics once we could start enteral feeding for him, then developed a hospital-acquired infection, and now currently is on high-flow oxygen therapy. And again, I think the issue is really around how much more complex it makes the treatment for these children, and not just treating a well child who just can have outpatient treatment and go on with their lives. And really around both the morbidity and potential mortality that both the child faces, but also the issues that the parents have to face in staying in the hospital over that period. So Lisa has gone through and really what this population is, in terms of, we're looking at adults and adolescents with a CD4 count less than 200, and infants and children less than 5 years are considered advanced disease. And the package of care includes a screening, prophylaxis, rapid ART initiation, and enhanced adherence counseling for children on antiretroviral treatment. So just to give you some data from South Africa, and this is data that compiles both the National Health Laboratory Service data, but also with the DHIS data. So if you look at the number of or percentage of children who have of CD4 count less than 200, around 10% of the CD4 counts done in the country is less than 10%, is less than 200. So again, we have quite a significant burden of advanced HIV disease in the adolescent population. This compares to about 19% for the overall population. And if you break that down further, so in your 5 to 15 years, it's about 8%, and in the 15 to 19 years, that's about 14%, and yet that gets a bit more closer to the adult data. So part of that is really around that difficulty in transitioning adolescents between pediatric and adult care, and how children and adolescents get lost during that process. But also part of that is actually our monitoring strategy, and this may be just a sampling bias, and we do stop testing our CD4 counts once children have a normal CD4 count. So these are those numbers in terms of the children who are doing well are actually underrepresented in that older population. And that really comes from the issues around viral suppression rates. And if you look at our viral suppression rates in South Africa, and you can see, in the adult population over 20, it's around 83%. If you look at the viral suppression rate using a cutoff of around 1,000 copies per ml, and around 66% looking at a viral cutoff of 50 copies per ml. But it drops down quite significantly once you go down below that period. So it's about 76% and 55% in that older adolescent age group, with the cutoffs of 1,000 and 50 copies per ml. So if you look at this over time, and I've just put in there the time of the introduction of TLD into the adult program, and we're very lucky that we started off using dolutegravir from over 20 kilograms from that stage. And there's been a steady increase in terms of the suppression rates for adults over that time. For adolescent girls and young women, it runs quite a bit lower than the adult figures. But for adolescent boys and young men, that's far lower than girls and the adult population. And this is much, much lower for the children less than 15. So that 15, our suppression rate sitting around 73%. And if you break that down in terms of, when you look at that blue line, which is right at the bottom, which is when you break it down to less than 5 years of age, and those are really where our problem is in terms of getting suppression down. So that's only 62% of those younger cohort is suppressed. And we haven't really started in terms of our dolutegravir rollout, and we hope with the expanded access to it that we'll see that suppression rate reaching up to the adult levels. And the other issue is really around diagnosis and getting these new children who are both in terms of preventing new transmissions, but also in terms of identifying and then starting those children on treatment. So I just want to draw your attention to in terms of, so the Tembisa model is really around modeling the data for South Africa, looking at new infections. So there's an overall drop in terms of the new pediatric infections overall. The line in the green is really around the new infection rates that's found, and there's a gap between what's identified in terms of the Tembisa model and what we're actually finding. And those are these lost children that are not being diagnosed and maybe dying at home and not accessing care before they die. So again, although those numbers are decreasing, we still see a large number of children who are not accessing care and not being diagnosed over time. And what we're seeing is that there's a steady drop of both data in terms of new infections, both in terms of the NHLS data, but also in terms of the DHIS data, which is the hospital level systems data in South Africa. Overall, what it does look like is South Africa is reaching case rates that will make the country eligible for bronze status. So the case rates are decreasing overall in South Africa, which is good news, but the problem is the volume of patients and HIV-exposed infants are relatively large in our population with a high incidence. And our testing coverage rates have also increased significantly over time, both in terms of at the 10-week period. However, as you move along, that decreases over time. So just to go quickly in terms of our testing and screening, so this is a new guideline in terms of the testing for prevention of TB diagnosis. And you can see that the 12-month INH prophylaxis, the 3-HP regimen, and the 6-month INH regimen are all in that guideline. One of the issues is access to medications, and certainly in terms of the 3-HP regimen, we don't have access to regimens for children. And there's several different issues in terms of access, and this is a study looking at really around knowledge, both in terms of parents, but also in terms of healthcare workers. For screening and prophylaxis, we reflex test all children, all samples for a CD4 count less than 1,000, and this is a study that we did in KZN that found relatively low incidence of cryptococcal disease in children, and predominantly it was seen in the 15 to 19-year-olds. For PJP prophylaxis, there's been some change in terms of the guideline, so we've switched down in terms of HIV-exposed in children, so they are no longer eligible for cotrimoxazole prophylaxis. And cotrimoxazole prophylaxis will be started once we make an HIV diagnosis. And this comes from two studies really around that there's limited benefit of cotrimoxazole prophylaxis uniformly given to all HEU individuals. For enhanced adherence counseling, what has worked well is really around tracing and identifying children in terms of the way they've missed visits, around a 7-day recall, and re-engaging them and getting the social workers to get those patients back and re-engage in care. And however, there's a lot of issues in terms of actioning those processes and making them come back into care. So just to make a few conclusions, again, I think the adolescents 15 to 19 are probably the highest risk of immune suppression, and we really need to find interventions that are targeting this population group. And just to bring up what Annette said, really we need to engage adolescents in developing what those strategies should be. We do see some positive signs in terms of viral suppression rates with the advent of dolutegravir. However, we have very low suppression rates in those youngest children, less than 5 years of age, and we really need to have access to dolutegravir and other systems to engage adolescents and their families to continue care and maintain virological suppression. So that ongoing strengthening of efforts to retain children and adolescents with HIV and improve viral suppression overall. Thank you.